we all know that SLE is a chronic multisystem autoimmune inflammatory disease, and pediatric SLE is a rare disease which presents prior to 18 years of age. Pediatric SLE represents approximately 10% of SLE cases with an incidence of 0.3 to 0.9 per 100,000 children years. A 9-year-old girl presented with both eyes decrease in vision with pain and redness for the past 15 days with fatigue, anorexia, fever and arthralgia. And she had a butterfly rash with diffuse erythematous non-pruritic rash over the malar region, chest, abdomen, back, palms for the past 1 month. This is what the fundus picture looked like. There was extensive changes in the retina with disc hyperemia, CME, and peripapillary areas of graying with extensive perivascular sheathing. This is what the OCT showed with this CME, gross CME with a neurosensory detachment and a bacillary layer detachment. Prior lab investigations, there was microcytic hypochromic anemia with leukopenia. A differential diagnosis at this time of leukemic, anemic, lupus retinopathy was made. These were the systemic investigations which we did. Serum ANA was positive. ENA antibodies were strongly positive, and serum complement was low. Rheumatoid factor and anti-double-stranded DNA antibody was negative. Our patient fulfilled the diagnostic criteria laid down by EULAR or ACR with positive ANA as entry criterion and a high total score of 20 for the clinical and immunological criteria. Patient underwent, she was diagnosed as retinal vasculopathy secondary to pediatric SLE and juvenile dermatomyositis, a kind of an overlap syndrome. She was given 3 doses of pulse IVMP, oral prednisolone 10 milligrams twice daily, followed by oral HCQS 100 milligram once daily. Subsequently, she was managed with IV cyclophosphamide, 6 consecutive monthly doses, and oral azathioprine. CBC, LFT, KFT were monitored monthly. They were within normal limits. For the eye condition, she also received topical steroids. So this is the 6-month follow-up visit. There was both eyes disc pallor noted with complete resolution of CME and subretinal graying, cotton wool spots and perivascular sheathing had all regressed. And you can see in the angio, which is courtesy Dr. Diksha Katoch at PGI, that there was the disc was hot, but there were capillary non-perfusion areas more so in the left eye in the periphery, and she underwent a laser photocoagulation to those areas in the left eye. At the latest follow-up at 1 year, vision is 6.6 OD and 660 OS, and she's continued on tab azathioprine, tab HCQS, and tab prednisolone. And this is what the fundus picture looks like. You can see the laser CR in the periphery in the left eye, and there's no CME in either of the eyes. So pediatric SLE has a less pronounced female to male ratio, higher frequency of renal, hematological and neuropsychiatric involvement, higher disease activity, more organ damage and worse outcomes. SLIC criteria had greater sensitivity than the ACR criteria for pediatric SLE. Lupus retinopathy is essentially an immune complex mediated vasculitis, or it can also be due to hypertension induced nephropathy. Retinal microangiopathy, vasculitis and severe vasoocclusion are seen. Also choroidopathy is also seen. Treatment of ocular manifestations is with systemic immunosuppression in the form of HCQS, systemic corticosteroids, azathioprine, cyclophosphamide, methotrexate, mycophenolate mofetil, and biologics. Local therapy in the form of laser photocoagulation and anti-VEGF injections, and finally vitrectomy have been described. So ophthalmic features are not a part of formal diagnostic criteria of SLE, and there's a discrepancy regarding which, if any at all, ophthalmic findings are included in disease activity scoring systems for SLE. Retinal involvement essential clues to disease activity due to the direct visualization of vascular phenomenon, and active lupus retinopathy is known to portend systemic flare-ups, and a multidisciplinary team approach with a pediatrician, rheumatologist, and ophthalmologist are required to provide optimum patient care. Thank you.